All right, we are live. So thank you guys for joining me today. See if we get any more that join in. If not, I am recording it so the rest of them can watch it later if they want to. But thank you guys for joining me on this journey, and we're to the last session. So we made it almost in 2 hours. We'll make it. but yeah, today is going to be the multi-system review. So this is kind of everything that that's not really covered in the other sections. It involves more systems than just one or the other. So we'll get going. So the test plan for this for the multi-system section is 13% of the test. So that ends up being 19 to 20 of the 300 questions, or not 150 questions. And this is all the different things that it covered. We'll get through most of these today, and I had high hopes of adding to the outline that I sent you guys a couple of the things that aren't on here, like or the things that are on the test plan that I didn't include in the outline, like post-transplant complications. But today kind of got away from me, and I spent a long time putting together the practice question presentation and poll questions, and then my computer crashed and I lost all of it. So I had to spend more time doing that and couldn't really add to it. So I'll kind of mention a couple things about post-transplant, but that's going to be something you'll want to self-study if you can. So just like thinking about, well, I guess I'll go ahead and talk about it. So just thinking about the phases of rejection. So there's like the acute phase right after transplant, moving into more long-term complications, including things like post-transplant lymphoproliferative disease. I always get tongue-tied saying that, PTLD. So that's an important thing to learn about. And I included a couple practice questions just so we kind of get at least a little bit of the review of it. But I apologize for not adding it into the outline. But so just, phases of rejection and different things you do in the immediate post-transplant period. And a lot of the practice questions I did see some questions about both post-cardiac transplant and kidney. I didn't see a lot about liver, but the ones I have included for today are the kidney-related ones. So yeah, study that in your review before you go take the test. Because we're not going to cover it today. But to start off with, pediatric sepsis. So this is a big part of the test. They like to ask a lot of questions about either sepsis or shock, septic shock, SIRS, and we'll go through all of those. So just to start off with, sepsis is a major health problem in the United States. It accounts for about 750,000 admissions annually, and that is adults and peds total. So about 42,000 of that is pediatrics. The mortality rate for adults is 25 to 30%, which is pretty high and scary. But for pediatrics, it's much lower, more like 2 to 10%, depending on what you look at. But it's still a big, you can see there the kind of cost estimates of how much it's costing per year for those kind of problems. And it seems to be on the rise, especially in the pediatric population. And it can lead to, it's a big thing to look for. We have kids admitted for infection for, some other thing that can progress to a full multi-system sepsis picture. And so early recognition and early response is really important in how well those kids do. And so it can lead to kind of serious safety events if you miss that, if you miss the early warning signs and catch it late. The later you catch it, the worse they do. So early recognition can help prevent some of the serious safety events from missing it. So what is it? Sepsis is a spectrum of this is a mouthful. It's, a pathological response to an infection. So you have, with sepsis, you have to have some kind of infection. We'll talk about SIRS, which is, the kind of same looking kind of picture without an infectious agent, or with or without. And then sepsis is kind of a category of SIRS or related to it. But so you have some kind of infection happening, some kind of bacteria, virus, et cetera, that's invaded your body, goes usually, throughout the whole body. You're going to see positive blood cultures. It's going to be kind of gone from one localized source of infection and spread throughout the body. And the problem with this is that you have all your inflammatory responses to infection, which are good in a localized area and even systemically, but it's when that inflammatory response gets out of control that you can really start to see problems. So you're going to see inflammatory mediators, anti-inflammatory mediators kind of competing against each other. The coagulation pathways are going to be activated and can start to get out of control. You're going to start to see, as it progresses, more cardiovascular dysfunction, problems with tissue perfusion, and then eventually, as your perfusion decreases to all your tissues and organs, you're going to start to see those organs start to not function like they should. So you have to have kind of a couple different things. Again, an underlying infection that's a part of sepsis. If you have that whole inflammatory response without an infection, it's just SIRS, systemic inflammatory response syndrome. So sepsis is SIRS plus an infection. And so to recognize it, you kind of look for some different factors, and we'll kind of touch on those, but you're going to look for fever, leukocytosis, tachycardia, tachypnea, vital sign changes, things like that. The definition is, I have it there. You're not going to have this on the test, but it's based on a 2005 sepsis consensus conference that kind of came up with the definition. So taking a step back, what's SIRS? Systemic inflammatory response syndrome. So this is an inflammatory response to illness or injury, and it can happen from hypoxic ischemic injuries that you have, during shock or some kind of low perfusion state. But any kind of illness or injury can trigger this. It doesn't have to be an infection. It could be some kind of trauma. We'll talk later about different ingestions, but the different things that can cause ARDS then can cause a whole SIRS. So whereas ARDS is kind of localized in the lungs, think about SIRS is throughout the whole body. So you have that normal local reaction at the site of an injury or an infection. It can be either one. And then it progresses to a systemic response that's kind of over-exaggerated. So the key factor is this endotheliopathy, but it causes at the very, lower level capillary leaks. That's going to cause that leakiness, that edema, that rushing of fluids and fluids and different inflammatory mediators, white cells into the tissues. You're going to have vasomotor paralysis, leukocyte infiltration, coagulopathy. Again, those coagulation factors are going to be a little not working like they should, or overreacting, and then you don't have enough of the coagulation for where you need it. Myocardial depression, so cardiac dysfunction, and then immune compromise, because you're using up all your leukocytes to overreact to something that may or may not need that strong of a reaction, and you're left with not enough to fight an actual infection. So to recognize SIRS, you have to have greater than or equal to 2 of these abnormalities. So an alteration in temperature, and this can be hypo or hyperthermia, so less than 36 or greater than 38, and that's a core temp, so this has rectal. Increased heart rate, so tachycardia, and this is, above whatever their age-related range is. Tachypnea, or a CO2 level less than 32. And then an abnormal white cell count, so either more than 12,000 or less than 4,000. You can see either one, too many or too few white blood cells, or more than 10% bands. So that's that left shift that we talked about with bands, which are the new, freshly made white blood cells. It means your body's producing a lot, which means they're using up a lot for an infection. So in children, one of the two has to be either temperature or white blood cells. So you have to have either an alteration in your temperature or an alteration, high or low white blood cells, and then one of the other two. So it can be both those two things, or it can be fever plus tachycardia, or abnormal white cells plus tachycardia, etc. But one of the two has to be fever or white blood cells, not fever, temperature or white cells. So there's different stages. First of all, you have stage 1, that's the inflammatory response to the local event. So you have some kind of traumatic injury or ARDS or some infection in a localized area. So you have that localized response. And then in stage 2, you start to mount a systemic response to that. Stage 3, you go into a massive inflammatory response. This is where the overreaction starts to happen, which leads to shock. Stage 4, you're going to see immunosuppression, again, because in stage 3, you're using up all of your normal immune responses, which leaves you immunosuppressed after that. And then stage 5, you're going to start to see multi-organ system failure because you're in that shock state. Your organ perfusion is not going to be as good, which is going to affect your organ function and lead to failure. So how do we manage this? First, you got to treat the underlying cause. If it's an infection, which categorizes it as sepsis, treat the infection. If it's from some kind of trauma or other injury, you're going to want to try to isolate that and treat that. And then in the meantime, you're just going to manage the symptoms. So manage the coagulopathies, giving FFP if you need to, giving platelets, clotting factors, try to manage any bleeding that's happening, and then manage that endotheliopathy, that overactive immune response or inflammatory response. So again, stopping whatever the underlying cause is, giving fluid resuscitation, increasing the plasma oncotic pressure because, again, your tissues are becoming leaky, so try to increase your osmotic oncotic pressure in your blood. So giving colloid administration is important for that. And then vasoconstriction, alpha agonist, that's your pressors for epi, norepi. All right, so the 2005 Pediatric Sepsis Consensus Criteria defined sepsis as, it's sepsis plus SIRS plus an infection. And if you're in severe sepsis, that means you have sepsis, so you have an infection, and that SIRS response plus organ dysfunction. So this is where you're starting to see that organ dysfunction. And then septic shock is sepsis plus cardiovascular dysfunction. So you're starting to see that decreased output, abnormal perfusion, that whole shock picture. So this cardiovascular dysfunction will lead to abnormal perfusion, may or may not see hypotension. Initially in the beginning stages, you're not probably going to see hypotension in kids. That's more of a late sign in children. They're able to kind of maintain that BP for longer until all of a sudden sometimes they fall off a cliff. So how do you assess tissue perfusion? If, like we said, kids, their blood pressure is not the first sign, not the best indicator to see when it's starting to happen, what do you look for? Well, you're going to look for all those signs of perfusion to your organ system. So to your brain, do they have altered mental status? To their, peripheral, do they have delayed cap refill or flash cap refill? Either it can start with bounding pulses because they're really trying to compensate, progressing to diminished pulses. You're going to start to see a widening pulse pressure. So that's your systolic minus your diastolic. But again, this kind of isn't still in the category of blood pressure where it's a later sign. And then all these kind of, cool extremities, acidosis, you're going to start to see an elevated lactic acid because they're not able to get oxygen to their tissues. They're starting to convert to that anaerobic metabolism. We'll talk a little bit about that too. So how do you respond to this? What do you do to manage it? Well, we use evidence-based guidelines. Again, there's this, from that sepsis consensus and then this sepsis surviving campaign guidelines. We're all pretty familiar, I hope, with our sepsis bundle. We have a whole algorithm to go through of how we hopefully identify an early intervention. And like it says at the bottom here, usually goal-directed therapy is a hot term for sepsis intervention. So goal-directed therapy means we're trying to target those end goals, which is increasing tissue perfusion, either by increasing their blood pressure or through other ways. So in the first few minutes, again, recognition, making sure you see that it's happening and intervene as soon as you can. So, couple of those things we talked about, the 4 criteria as far as fever, white cells, tachypnea, tachycardia. White cells you might only see on a CBC, which, who knows how often you're getting that. But the other thing is, that's why frequent temperature monitoring and vital sign monitoring, especially for kids who are at risk for sepsis. So you'll have your vital signs for that. And then again, recognizing those other signs, altered mental status and other signs of decreased perfusion. You're going to want in that first few minutes to start oxygen. Any kid with shock should be getting on oxygen. They're having issues with tissue perfusion. Even if their SATs are good, we want to get them as much oxygen in their body as we can, at least initially. So throw some oxygen on. I think our protocol, that we have at Children's says the venti mask at 50%. It doesn't need to be 100% to start, but at least get them something going. Intubation if needed. That's of course if it's getting worse or if you're really starting to see them decline. And then getting some IV access. You want to at least get a PIV. The central line is the first choice, but you don't want to delay interventions in order to get a central access. Usually takes a while. And in that first 15, 20 minutes, you want to be giving them IV fluids, hopefully getting a culture. Our algorithm has us starting antibiotics within the first 60 minutes. Central lines are going to usually take longer than that. So first thing is going to be getting a PIV or an IO if you can't get that. So again, fluid resuscitation. So the first 10 to 15 minutes after you're recognizing that sepsis is starting, you should be starting some fluid. The gold standard is 20 per kilo bolus of crystalloids over 5 to 10 minutes. It should be no longer than 20 minutes. Other than that, I used to joke, one of my preceptors used to say, a bolus over an hour is just a rate change. It's not a bolus. So these fluid boluses should be going in ideally 5 to 10 minutes, no longer than 20 minutes. And unless you see something in the questions that makes you think they have some kind of cardiac picture, it's going to be 20 per kilo. Again, for cardiac kids, it's more like the 5 to 10 because we don't want to overload their heart. So you're probably going to start with normal saline, though. A lot of our docs are trying to get away from that and do something like plasmolite and LR. That's something more normalized to what their blood chemistry actually is. And then it's continual reassessment. You're probably going to need more than one bolus. You could be given 20 per kilo, then another 20, up to a total of 60, 80, even 100 per kilo. Though after about 60 per kilo is when you start thinking about other things. So how much fluid do you give? Again, you're going to keep giving it until you see improvement in, their vital signs, urine output, peripheral pulses, level of consciousness. But if you start to see signs of fluid overload, then that's when you need to think about stopping. So hepatomegaly, if you can start to feel their liver, RAWs or, crackles in their lungs, any other signs of fluid overload, you're going to want to stop and think about other things. Antibiotics should be in the first 60 minutes. Ideally, we want to get a blood culture first, though we don't want to delay antibiotics for a blood culture. So again, early intervention, antibiotics within 60 minutes is the most important thing. Blood cultures are good if you can get them, but should not delay your care. And if you can't get IV access, you can try or look for IM administration. And then early and aggressive source control. So again, if you can ideally get that blood culture, you're going to start with broad spectrum. We start with Vanc and Cephatax, or it depends what the kit is. But then as we get those sensitivities within 2 or 3 days, hopefully from the culture, then we can narrow it down as soon as possible to just hopefully 1, if not 2 antibiotics. So vasoactive support. So these are some different, some things you're going to start using for what we call fluid refractory shock. So once you've given that 20, 40, 60 per kilo and you're not seeing improvement, then you need to start thinking about adding some vasopressor or inotropic support. So which kinds do you want to use? So it depends what kind of shock you're in, what stage you're in. If it's a warm shock, which is, flash cap refill, bounding pulses, you're going to start with norepi and dopamine. And if it's cold shock, you're going to do epi and dopamine. And then if it's low, can't read this from the thing, low cardiac output, low systemic vascular resistance. So that's cold shock with a low BP, again, dopa and epi, but you're going to start to consider other things like milrinone or dobutamine. Okay. This is just another graph I included in your outline of some other, more information about how they work, whether they're alpha or beta, what your normal dose range is, though they probably won't ask you the exact dose, but it's useful to know, well, just for our job, it's useful to know what they're for. And then why you're giving them. Dopamine, sometimes we see low dose for this just to help with renal perfusion. So if their urine output's low, but their blood pressure is not that bad, you can start like 5 per kilo just for kidney perfusion. But it's also going to cause vasoconstriction. Norepi causes vasoconstriction, which is why you use it with warm shock to tighten up those dilated peripheral vessels. But epi is going to help with that as well. But anyway, so you can kind of review this for your own in your own time. Milrinone is another important one. Milrinone, think of heart failure, but also, so think of squeeze and also vasodilation, because that's what you want to give if the heart's not pumping good enough. So it helps with the squeeze of the heart, with the output of the heart, but it also adds vasodilation to decrease that afterload that the heart has to work against. So if you see milrinone, think heart failure. Okay, so refractory shock, again, they're not responding to the fluid, maybe not responding to those pressors. What else do we need to think about? So if you don't have a central line by now, you really need to be placing one. As soon as you start, pressors of any kind, you need to start thinking about a central line placement. And then think about their oxygenation, ventilation status. If they're that sick and that refractory, they're probably going to need a more advanced airway. And if they're still not responding, some other things to think about. Is it a catecholamine-resistant shock? About a quarter of pediatric patients with septic shock will have adrenal insufficiency, which means they're not producing the catecholamines and the cortisone response that they should, which helps, their own intrinsic management of their blood pressure. So we might need to give them a hydrocortisone stress dose, and then maybe check some hydrocortisone levels. But especially if they have like chronic kids, chronic illnesses, if they're on chronic steroids, especially, that's been suppressing their adrenal activity, they might need hydrocortisone. So if they're still not responding after O2, getting extra access, fluids, all the things that we just talked about, you're going to want to rule out some other reason that their cardiac output is being affected. So that is something that's causing pressure in or around their heart. So do they have a pericardial effusion that's squeezing their heart? Do they have a pneumothorax that's causing increased intrathoracic pressure? Do they have increased intra-abdominal pressure? If there's some kind of, trauma patient, especially, or have some kind of abdominal process, they could be going into abdominal compartment syndrome, which is going to, again, put pressure, on their aorta, but then eventually backs up all the way to the heart. You might need other more invasive lines like pulmonary arteries, PICOs, to kind of give you a better idea of all the pressures in and around the heart. And then a Doppler ultrasound, all those things there. Look at all that. And then if you're still not reversing that shock, you might need ECMO to give you some time to, them some time to heal and you some time to figure out how to help them. If they're in that bad of shock, it's probably going to be VA, because they're probably going to need that cardiac support as well, not just VV. All right, so just talking about shock in general, and some of this will be repetitive from what we just said, but we're going to just go over the other types of shock too. So the definition of shock is any acute disruption of circulatory function that results in decreased perfusion. So if you hear shock, think decreased perfusion. Which is going to result in an inadequate oxygen and substrate, which is just, all the things in your blood that your cells need, is not getting to them. And so your cell's energy production is going to go down because of that. So clinical criteria, hypotension. And again, this is a late sign in kids, but especially hypotension after fluid bolus. Tachycardia, that's probably one of the earlier signs. End organ perfusion abnormalities, those things we talked about earlier that show that your organs aren't functioning like they should, decreased urine output, mental status, all that. Lactate production, so this is where you're checking their lactates and seeing if it's elevated. Any evidence of altered oxygen extraction or systemic inflammation. So tissue perfusion, these are all the things that you need to perfuse your tissues. You need blood, something to fill the tubes. You need a pump, cardiac, your heart. You need vascular tone, which is all the tubing. You need good oxygen in that blood. And then you need cells that can use that oxygen and that energy. So in general, while we're thinking of shock, let's think of it as three main categories. So you got the pump, your heart, the tubing, your vessels, and the fluid, that's your blood. So these are the different kinds of shock. And really, it depends where you look. Really, there's three types of shock. This kind of has a separate, and I'll show you why. But cardiogenic, that means the heart's not working. Distributive, that's the tubing's not working. Hypovolemic, don't have enough fluid. Or septic, which is a type of distributive shock. A lot of places you'll see it under the distributive shock category. But the the reason it has it separated here is because you really see parts of all three problems. Septic shock starts as distributive. It starts as that systemic inflammatory response. So you're going to see vasodilation. But as sepsis progresses, you're also going to see hypovolemia because that fluid is leaking out into all your tissues and it's not inside your vessels anymore. And then you're going to start to have some heart function problems as well. So that it kind of, has components of all three of them. But technically, sepsis is a type of distributive shock. So let's just talk briefly about the other kinds. Hypovolemic shock. This is the most common one in children and one of the leading causes of death in children. So basically, it's basically decreased intravascular volume. They have decreased blood volume for one reason or the other. That leads to a decrease in preload. If you're not filling your heart with enough, it can't put out enough. So it decreases your cardiac output. So how does this happen? Well, you can either have an external fluid loss or an internal fluid loss. So under a year old, the most common is some kind of gastroenteritis or diarrhea. These are the kids who come in with 3 days of nausea, vomiting, diarrhea that have sunken fontanelles and tachycardia, and they just look like little prunes. So they're not able to keep up with that fluid loss. And then over a year, the leading cause is hemorrhage from trauma. So you're either losing, for some reason, the fluid from the blood itself, if that makes sense, either through vomiting or diarrhea or, other dehydration or not getting enough fluid in combination with that, or an actual loss of just the whole blood itself through hemorrhage. Other causes, just some things that you think of that can cause dehydration, hyperthermia, burns, are going to cause a lot of insensible losses, and nephrotic syndrome because you can be dumping a lot of fluid. Your kidneys aren't smart enough to hold onto your fluid. The diuretic phase of acute tubular necrosis and diabetes insipidus. So all of those are causing you to dump too much fluid. So you're going to classify it based on the severity of fluid loss. So mild, moderate, or severe. And again, either from dehydration or blood loss. So mild, most of this is going to look pretty normal. Alert and oriented mental status, their heart rate's usually pretty normal, might start to be getting a little high. Everything else is good. Mucous membranes are fine, fontanelle's fine. They still are crying, still have tears, pulses are fine. And they're in the 3 to 5% weight loss. So they've lost about up to 30 to 50% of fluid loss is considered mild dehydration. Once you get to moderate, this is where you're actually going to start to see significant change or start to see changes. So they're going to start to be a little irritable, a changing level of consciousness, some tachycardia. Their respiratory rate might start to increase as well. The blood pressure, again, because kids hold on to their blood pressure longer, might still be normal. But their mucous membranes are start to be dry, fontanelles sunken, eyes a little bit sunken. They're going to start to lose their ability to make tears and start to have decreased pulses. And this is in the 60 to 90 per kilo fluid loss. And you'll start to see decrease your output. And then severe dehydration, this is where they're definitely in a hypovolemic shock state. That hypovolemic shock really starts in the late moderate stage, but if they get to this, it's pretty bad. So this is where they're lethargic, they're severely tachycardic, respiratory rate's not right, hypotension, which again is a late sign. The mucous membranes parched, sunken fontanelles, still absent tears, weak to absent peripheral pulses, little to no urine, and this is where they have 100 per kilo or more of fluid loss. Now, the blood volume itself is only 70 to 80 mLs per kilo of your body weight, so all that fluid loss is not just from their blood. It's, as their blood volume goes down because of the fluid loss, it starts to draw fluid out from the tissues, and that's why it gets up to above, the normal, what the blood volume should be. So number one causes of hemorrhage is traumatic injury, but you can also get that from post-op bleeding, GI bleeding from esophageal varices or other things. And then if they have a bleeding problem, that'll cause it too. So moving on to distributive shock. So if hypovolemic shock was not enough fluid, distributive shock is a problem with the tubing, a problem with the vessels. So it's an abnormal vascular tone. It causes a relative hypovolemia because if you start with a tube that's this big and the fluid's filled up, once it gets this big, the fluid is not able to fill all that space anymore. So it's a maldistribution of the intravascular volume. which again decreases preload and decreases cardiac output. So this is kind of a picture of what it is. You've got the normal vessel with normal diameter, and then you've got too much vasodilation for some reason. A certain amount of vasodilation is good, and your body does it on purpose for a lot of things, but this is too much, and your body can't compensate. So it's going to, as it dilates, allow things to leak out, especially with things like sepsis. But yeah. So etiology, you can get this from a lot of different things. The big things that we normally think about and that you might see on the test is anaphylaxis, a neurogenic shock, and sepsis. But all these other things can cause it as well. So anything that causes a loss of sympathetic vascular tone, drug toxicities, hyperthermia, infection, adrenal insufficiency, and pancreatitis. So just to revisit, and I'll say about, I have a couple of practice questions about anaphylaxis, but I don't think I have any slides about it. The main treatment for it is going to be, it's some kind of anaphylactic allergic response to something. And if the definition of anaphylaxis is usually some kind of skin, local involvement plus respiratory involvement. So it's when you start to hear that wheezing and stuff that you really start to get nervous. And so you're going to want to treat with IM epi, and then, steroids and Benadryl as well. Okay, so revisiting septic shock. So again, this kind of has characteristics of all three, although it starts as a distributive shock, but it's infection that triggers a SIRS response. So etiologies, I won't go through all these, but this just kind of lists the most common ones that cause in the different age groups. And then different categories of shock. So how do we categorize it? So either cold or warm. So again, cold shock is going to be vasoconstriction. So you're going to be cool extremities, decreased pulses, prolonged cap refill, whereas warm shock is still bounding pulses. You still have vasodilation. So warm extremities, flash cap refill that's almost too fast, and bounding pulses. We also categorize it as either fluid refractory or dopamine resistant. So these are that shocks that's not responding to fluid, not responding to vasopressors like you'd expect. Catecholamine resistant, which is where, we've done the fluid, vasopressors, gone to hydrocortisone, stress dose, and it's still refractory. And true refractory is it's not responding to any of that, and which is going to lead to either death or, you can go to ECMO if you can, but this is not good. So what are some stages of shock? So you also hear these phrases, but compensated shock, it's going to have that normal BP. They're still going to look pretty normal. So their body is still able to mount a compensatory response to try to, compensate for either that pump failure, the hypovolemia, or the tubing failure. So either through vasoconstriction or some other way that the body is compensating itself. Uncompensated shock is when that stuff starts to fail. You start to see that lower blood pressure, and then irreversible or refractory. So how does your own body regulate blood pressure? You have neural pathways to do that, either through baroreceptors, volume receptors, chemoreceptors, different receptors throughout your body that say, hey, there's not enough output or there's not enough blood pressure, so let's compensate, through vasoconstriction or something else. Humoral is that catecholamine response, so your own inborn epi-norepi that's released, your renin-angiotensin system to cause, you to hold on to more fluid and increase your blood pressure. And vasopressin, which again is ADH, it holds on to more fluid. And then autotransfusion, this is your body's own ability to change the oncotic pressure to kind of shift fluid into the vascular space. So that's that kid who's dehydrated because of diarrhea or vomiting. They've lost a lot of fluid. They're not able to keep it down. Your body shifts fluid from your tissues into your vascular space. So those are all your own ways to compensate. But as those compensation methods fail, your oxygen delivery to your tissues is going to be impaired, which is going to lead to anaerobic metabolism. So what's the difference? Aerobic metabolism requires oxygen. It's how your cells normally function, normally produce energy. It's pretty efficient. We're not going to get into chemistry, but if you remember, ATP is what your body uses for energy, and aerobic metabolism with oxygen and glucose nets 36 ATP. If you have to switch to anaerobic metabolism, so using that glucose without oxygen, it's only going to net 2 ATP. So it's very inefficient. And the byproduct, whereas the byproduct of aerobic metabolism is carbon dioxide and water, your byproduct of anaerobic metabolism is going to be lactic acid, which is going to cause an acidosis. So how do your adrenal glands function in a setting of shock? So normally, cortisol is going to be released. It regulates that catecholamine synthesis, so it helps stimulate those other responses. And then if your body's not producing enough because of that adrenal insufficiency, we can give them high-dose hydrocortisone. So again, that's for those who are known to take steroids, have some kind of neurologic abnormalities, or have some kind of chronic prolonged critical illness. So physiology, what happens at the cellular level? So you start to have cellular injury as that perfusion decreases, that oxygen delivery decreases. You're going to have a hypoxic ischemic injury to those tissues. So that decreased energy production, because it's using that less efficient method of anaerobic metabolism, is going to cause a loss of structural integrity of the cells. It's going to cause the cell membranes to start breaking down, edema to happen inside those tissues, and eventually cell death. Once those cells die, they're going to break apart and release toxic substances and activate an inflammatory response. And then eventually your cells start to get to the point where they really can't even utilize the oxygen you are able to give them, and then this just further increases their cell damage. And that can also be made worse through poisonings, metabolic diseases, other things can make that worse as well. Okay, so how do we assess this? Again, assessing perfusion. I know a lot of this is repetitive, but it's important, and I feel like it's something they cover a lot on the test. So you want to assess perfusion with your heart rate, urine output, also blood pressure. If you have a CVP line, that's great as well, or an art line to get really accurate measurements. And then just look at their physical exam. For oxygen delivery, you're going to look at blood gases to try to see, measuring their arterial oxygen saturation versus their venous, to kind of see if they're able to get 100% sats coming out of their lungs, how much is the venous sat when they return? Are those cells able to utilize that oxygen? Lactate levels, CBC. And then again, looking at functions of each organ, so like LFTs, butyl and creatinine, things like that. So oxygen delivery, this is just, a little bit of what I was just saying. So you have, for oxygen delivery to happen, you have your cardiac index, which is your cardiac output and factors in your body surface area. Another factor of that is your arterial oxygen content. So you need hemoglobin, right, to carry the oxygen. So even if your sats are good, but you don't have very many of those hemoglobin to carry it to the cell, that's going to have a problem too. And then the partial pressure of arterial blood is how much is dissolved in your blood. So where your sat is how much is saturated in the hemoglobin, the partial pressure is dissolved in the blood, which is not as useful for the cells, but kind of gives you an idea of how much oxygen you're giving them. Components of oxygen consumption. So this is your cardiac index, and then again, the difference between your arterial sat and your venous sat to see how well the body's using the oxygen. So treatment of shock states. Again, we've kind of gone over this, but treat the cause, give fluids, vasopressors, vasoactive meds, treat acidosis and other symptoms as you can with bicarb if needed, and then, keep reassessing, resending labs. If shock goes on long enough, you're going to go into that multi-organ system failure. So the longer shock goes on, that's the longer those tissues have not been perfused, the more likely those organs are to fail. So the definition of multi-organ system failure, or you might see MODS, multi-organ dysfunction syndrome, is when there's a failure of 2 or more organ systems due to shock or SIRS. So it's caused by that hypoperfusion of the organs, causes the dysfunction, causes an endotheliopathy, which causes cell damage and death. So stages of this, there's some initial event that hypoperfuses the organ, some kind of systemic inflammatory response. Stage 2, you might, as you start to give them fluids, they might have a resuscitation, but also a reperfusion injury. As those cells have been damaged, you reperfuse them and you can get a reperfusion injury from that. Stage 3 kind of has 2 parts, but there's a hypermetabolic state where cells have increased oxygen. You've reperfused them. They're trying to go into overdrive, but stage 3B is like an acute respiratory distress syndrome, where if that's one of the organs failing too, you might have oxygenation issues. And then stage 4 finally is multiple organs failing due to persistent deficit of oxygen delivery. Basically, the perfusion's been decreased too long and they can't recover. All right, so that's sepsis, shock, SIRS. Sorry, that's kind of a big subject, and we could, I think, talk about it for probably 2 hours on its own. But hopefully, that's a good enough review for you guys to get started and go over for that. But let's move on to the next section. So this is healthcare-acquired infections. So CAUTIs, CLABSIs, we used to call them VAPs, but ventilator-associated events. We talked about CAUTIs last week with the renal module, so we'll just talk about briefly CLABSI and VAE. And I know, at least in the PICU, I don't know how it is in cardiac, but we have been harping on this for a long time, so I know this is going to be something you all know very, very well. But CLABSIs are a big problem in healthcare in general. It's an infection that occurs when a bacteria or virus enters the bloodstream through a central line. It results in thousands of deaths per year, billions of additional healthcare costs, and of course, when these are healthcare-associated infections, we don't always get reimbursed for them either, which is another problem. But so how do we prevent this? We have all of our bundles, our insertion bundle, maintenance bundle, making sure we remove that catheter as soon as possible. So making sure we're assessing for that need daily, and then using checklists for insertion and maintenance. Ventilator-associated events used to be called ventilator-associated pneumonias, but this also increases morbidity, mortality, ventilator days, length of stay for our intubated patients. So again, we use VAP prevention bundles, so good oral care, head of bed above 30, daily assessment of, are we ready to wean from the ventilator, and then making sure the equipment's maintained, sterilized, tubing's changed out regularly, things like that. Okay, toxin and drug exposures. This is overdoses or any other kind of exposure. The Poison Control Center data, if you want to look at their website, has some kind of interesting interactive graphs and statistics. But this is kind of, I don't know why this crossed over weird, but this is their 2018 data. So age less than 5 years, these were the most common types of substances they were exposed to. So the less than 5 year category is the biggest one. It's 927,000 cases, which is 75% of the pediatric cases, but it was like 44% of all the cases altogether. I think there were about a little over 2 million cases reported to poison control centers in 2018. So just age under 5 made up almost half of that. But most commonly they get, and this is, these are the unintentional. They get into something, they eat something, kids eat everything. So cosmetics and personal care products, cleaning substances, they will get into prescription and non-prescription pain relievers, foreign bodies, toys, and then topical stuff. So not a lot of pills, I think we're doing better with making childproofing and things like that, but they do get into and eat, a bunch of things. Age 6 to 12, higher percentage of that was foreign bodies and toys. Again, prescription, non-prescription, cosmetics, antihistamines, and cleaning substances. And then 13 to 19, this was 14% of the cases. And interesting to me, and I think kind of it makes sense, but 66% of the cases reported to Poison Control Center were intentional. So sometimes it's not intentional. They're not trying to harm themselves or overdose necessarily. Sometimes it is not, sometimes they're just trying to get high and not necessarily cause harm to themselves. But these are where it's going to be all some kind of drug, prescription, non-prescription pain relievers, antidepressants, sedatives, antipsychotics, antihistamines, and then street drugs. So common culprits in kids less than 5, because again, that's the majority of the cases, but you're going to see medications, cosmetic, cleaning substances, just the things you think about around the house. Pesticides, which we're going to talk about in a second, are also called organophosphates. And then hydrocarbons, that's like your kerosene, gasoline, things like that. This is a list of just the highly toxic ones. I'm not going to go through all this. Sorry about that. That's the puppy and construction noise I talked about earlier. Sorry about that. Go. It's okay. Okay, I'm not going to go through all that, but I included it in your outline. So general principles. In general, you have some kind of overdose, some kind of toxic ingestion. What do you want to do? So try to prevent absorption as much as you can. So if it's in their eyes or on their skin, irrigating. For their GI tract, Ipecac is usually not recommended. You usually don't want to induce vomiting, especially if you're not sure what they took. But a gastric lavage, a whole bowel irrigation, cathartic, so that's like laxatives, and then activated charcoal to try to absorb the medication or whatever it was. Taking a good history, trying to find out what it was, especially when it's younger than 5. Sometimes you know what they took, but sometimes you're not. The parents aren't super sure. They're just like, they're acting funny. It seems like they got into something, but they don't know what. And then enhancing elimination. So this, you might have to use something like dialysis, pheresis as well. And then we have antidotes, if you know what it is. So we'll go through some of these in, individual detail, but these are some of the antidotes you can see. You've got acetylcysteine or mucimist for Tylenol, digoxin immune fab for digoxin. So if you have a high digoxin level, you can give digoxin immune fab. I don't even know what those are. Supportive care. So symptom management, you can, there's a lot of, depending on what symptoms they're showing, a lot of things you can do. And then trying to prevent future episodes. So if it is an unintentional thing, like what can we do to make sure they're not getting into that stuff? Maybe some family education. About proper ways to store things. I think we've had a kid before that drank something out. They stored some kind of like tiki oil lamp in, a Gatorade bottle or something. I forget what it was exactly, but you've got some really not that smart people that store dangerous things in bottles that look like something else. So that's never a good idea. So it might be family education. If it is a teenager who's intentional, you might need to look into further psychiatric or, interventions for that. So toxidromes. This is a term that means if you don't know what they got into, you kind of categorize their symptoms to then see if you can narrow it down and figure out what they took, or at least what category of things they took. So this is some of the more common toxidromes. So anticholinergics, antihistamines like Benadryl. You're going to see increased heart rate, increased blood pressure, increased temp, delirium, psychosis, big sluggish eyes, flush dry. So I included this on your outline so you can I would memorize these if you can. Because one thing I found from going through a lot of the questions and practice questions is, we've got I'm going to cover some of the most common ones today of what they might ask about, but it seems like they always ask some random question about some med that you've barely heard of, or some, substance that it's hard to go over and memorize every single thing that they might ask about, because there's a lot of stuff kids can get into. So we'll go over the most common ones, and hopefully, if you do see a question about something you haven't heard of before, it's just one question. So household items, so bleach, you just think about how caustic that is, but it's going to cause damage to their mouth any part of their tract that they swallow it down. And then, if they inhale it at all, respiratory distress. Any acids or alkalines are again going to cause damage and irritation locally on their mucosa. Ethanol or alcohol, this is going to cause CNS depression and hypoglycemia. The CNS depression can then lead to respiratory compromise. What are some complications of caustic ingestion? So acids, bleach, alkalines. So it's going to cause those esophageal burns, which as they heal can lead to esophageal strictures, which can cause some chronic complications, problems swallowing, and increase their aspiration risk. Organophosphates. So this is a big category. Well, it's a dangerous category. It's like pesticides, insecticides, things like that. But the thing that makes these so bad, and they've tried to, that's why there's more and more out on the market now that aren't as dangerous or as bad. But this causes an irreversible cholinesterase. It's an irreversible cholinesterase inhibitor. So the organophosphates actually bind to cholinesterase, acetylcholinesterase, and prevents the breakdown of acetylcholine. And what that's going to do is that extra acetylcholine is going to overstimulate their autonomic nervous system, their parasympathetic nervous system. So think of all of the things that are associated with that. So it's called muscarinic signs. And the one acronym they have here is SLUDGE. So salivation, lacrimation, tears, urination, defecation, gastrointestinal distress, emesis. So an overproduction of all their secretions, all the things coming out of them. And you can also see nicotine effects. So this is going to be the skeletal muscles that initially exhibit vasculatation. Oh, I don't know why they have such weird words on here. Anyway, the involuntary irregular muscle movements gradually progresses to muscle weakness and muscle paralysis. So in addition to increasing all your secretions of all your things, you have increasing weakness and paralysis. So the big main concern with this is respiratory failure from those excess airway secretions. And that's going to be made even worse as those muscles get weaker and paralyzed and they can't cough them out and mobilize them. So you're going to do frequent and active neuroassessments, watching for that progressive weakness and paralysis. You can check serum cholinesterase levels. You can give them activated charcoal if it's early enough in the process. Usually activated charcoal, you're going to want to give it within an hour. We'll see that Tylenol is an exception to that. But the big treatment for this is atropine. So that is going to block the action of, you have too much acetylcholine because it's not getting broken down. That's going to block the action of acetylcholine peripherally. And what that will do is decrease all those secretions. So we normally think of atropine as, for heart rate problems. So it's for bradycardia. In this case, in organophosphate overdose, it's not for bradycardia. So even when you've normalized their heart rate, you're going to continue giving this because your target is drying up those pulmonary secretions, because that's what these kids die from. They drown in their own secretions. And then you can give pralidoxime, and that is going to bind to that organophosphate inactivated acetylcholinesterase. But it has to be given within 48 hours. It helps with that muscle weakness and paralysis, but it has to be given in 48 hours because after that you have that's when it becomes that irreversible inactivation of the acetylcholinesterase. Ooh, I made it. All right, Benadryl. So this is one we see a lot of, especially up in the ICU. I don't know why kids think to take this. Maybe it's because they think one Benadryl makes them sleepy, so a bunch is even better, but it kind of does the opposite. It causes hallucination, agitation. So you're going to see those CNS changes. It's an antihistamine and anticholinergic. Hypertension, tachycardia. You can see ventricular arrhythmias, bundle branch block. So you're going to want to make sure you monitor their airway. Give them activated charcoal if you can. If they have seizures, you can give them benzos and other anticonvulsants. But yeah, this is the ones where they see hallucinations. Because it's an anticholinergic antihistamine, you're going to see everything dry up. So dry mouth, blurry vision, dilated pupils, all of that anticholinergic things that you think of. Iron. So with this, you're going to see GI symptoms. It can cause liver damage, cardiac damage, respiratory, central nervous system. You can see symptoms in all those areas. The big things to remember with this, give them oxygen. It depends what problems you're seeing from it. Chelation therapy is usually, so gastric lavage, if it's early enough, if they, for instance, got into mom's multivitamins with iron, took a bunch of those pills with iron, you want to try to gastric lavage, get that out of their system if you can, whole bowel irrigation to try to flush out their whole bowel. This is one where activated charcoal is not going to help. Activated charcoal does not bind to iron, so that's not going to be your solution in this situation. But the antidote is deferoxamine, and that's that chelation therapy that you might hear it as chelation, but this is the specific chelation agent for iron, deferoxamine, if their levels are above 500. Okay, opioids. So this is a big one, especially with the teenagers, though you have, the younger kids that get into it accidentally. Just as, one of the things I saw as a side note that some of our urine tox screens don't detect methadone specifically, even though they detect, other opioids. And then a thing to remember with this is a lot of opioids can be combined with acetaminophen. So your Tylenol mixed with, hydrocodone or whatever. So if they pick that to overdose on, they might also overdose on acetaminophen. And that's one thing, just as a side note, we'll get to acetaminophen in a minute. It's in, I think, over 100 different over-the-counter preparations mixed with different things, different cold medicines that have it, different pain medicines, headache medicines that are a mixture of things. It's mixed with a lot of stuff. So if there's ever a question about a co-ingestion of, they overdosed on one pill or one thing, what's another thing you want to also look for to make sure there's not an overdose of that? And it's going to be Tylenol, because that's very common. But back to opioids, you can see this with transdermal patches. A little kid picks up grandma's fentanyl patch or something and chews on it. CNS and respiratory depression, it's going to cause hypotension, arrhythmias leading to cardiac arrest. So management, airway support, and naloxone or Narcan. So this one you're going to want to make sure, I think I have this on the next slide. It has a shorter half-life than many opiates. So it's only going to last maybe as short as 20, 25 minutes, as long as 60 minutes, but probably not any longer than that, unless I think neonates were the one exception. It lasts 2 or 3 hours in neonates. But for the most part, Narcan, think 45 minutes. And a lot of the, especially over-the-counter, fentanyl is shorter acting than that, but a lot of the over-the-counter opioids, like oxycodone, especially if it's like OxyContin, those last hours. So your Narcan is going to wear off way sooner than your opioid is. So you might need a Narcan infusion until, if you give that one-time dose, you see that it helps, it might need a continuous infusion until that opioid is out of their system. Okay, sulfonylureas. So this is type 2 diabetes medicine. So they are going to cause hypoglycemia, loss of appetite, but you're going to do frequent glucose checks, dextrose administration, and you can do an octreotide drip because that helps inhibit insulin secretion, so you're not getting rid of the little glucose that is there. Okay, Tylenol. This is another, again, a big one that they like to ask about, an important one. We've, just this week had one actual Tylenol overdose and one pretend Tylenol overdose, but this is one that is bad because I don't know why kids pick this one to do. It's not a very good one. It doesn't kill you right away. It just causes a lot of long-term problems. So liver damage can occur anytime you take more than 150 per kilo in a single dose or at one time. And there's multiple stages of this. So we've had, I remember a few years ago, we had a girl come in who took a bottle of Tylenol, was not awake when they found her, and, got a liver transplant within a couple of days. So you can have complete liver damage and failure from this. But stage 1 happens within the first 30 minutes to an hour. It's going to cause nausea, vomiting, diaphoresis, pallor, lethargy. And then stage 2 is where you start to see those increasing LFTs. So in 24 to 72 hour range, you're going to see the ALT, AST, PT, all of your coags increase. Think of anything that your liver is responsible for doing. All of that's going to go out of whack. Your liver is going to become enlarged and tender. And then in stage 3, one thing I read said, if you survive stage 2, in stage 3, you might see, this is where your LFTs are going to peak at whatever, depending on how much you took, whatever level they're going to peak at. You're going to see an increased bilirubin. You might have renal failure that is, as resulting from all of that, and then you can have death. So for this activated charcoal within this is one where it's instead of set within an hour of ingestion, it's said within 4 hours, because you really want to absorb as much of that Tylenol as you can from their gastric system. And then the antidote for this is N-acetylcysteine or Mucomyst. So that's going to prevent the formation of free radicals that results in the toxicity. It's most effective if given within 8 hours of the overdose. So usually there's like the one first bolus dose, and then you give another dose over, I can't remember, 6 hours, 4 or 6 hours, and then a third dose over 18 hours, I think. For Tylenol levels, you can check one right away, but the first most telling one is going to be 4 hours post-ingestion, and then, you check them serially after that. Cocaine, this is the one where the little kid gets into it and mom and dad have no idea where it came from. But it's going to block your uptake of norepi, dopamine, epi, serotonin, which means if it's blocking the uptake, those are going to accumulate in the system. So think of what happens when all of those are elevated. You're going to have tachycardia. Your heart's going to be pumping out of your chest, tremors, diaphoresis, pupil dilation. Whereas with opioids, you're going to see pupil constriction, vasoconstriction, hypertension, and hyperthermia. These are kids that can come in with very high, like 104 temps from cocaine overdose. So to manage this, you're going to give them oxygen, make sure you put on EKG check for arrhythmias, manage their hyperthermia, cool them down, give them benzos to decrease that heart rate, decrease that blood pressure. It's a CNS depressant because they're getting all these stimulants you need to kind of depress to balance out until it wears off. And then you can give sodium bicarb for the acidemia and arrhythmias that you see, but no beta blockers because that can burn out their heart. Next is rat and mouse poison. So these generally work by having anticoagulant effects, and they can last up to 7 weeks. So depending on how much they got into, if it was more of a chronic issue or, all at once, you're going to want to monitor their coags, monitor their prothrombin times for at least 1 to 2 days. You can give them vitamin K. And then some others that I would recommend that you review that I didn't get a chance to add into this slide, but based on some questions, I've seen review questions and see these might be some things you want to review yourself. So lead overdose. And important things with that, I'm trying to remember, is that it usually can lead to seizures. It's usually like altered mental status seizure kind of things. You can do chelation therapy with that, but it's not the same one as iron. Hydrocarbons, that's like kerosene, gasoline, things like that. Usually what you're worried with that, it's obviously going to be irritating to their mucosa, and, if they swallow it. This is where you can see a chemical pneumonitis from inhaling it and kind of causing a pneumonia from the chemicals. But you can also see seizures from those. Antidepressants are a big one, tricyclics and MAOIs. And anti-seizure meds, opioids and non-opioids. So non-opioids, we already talked about acetaminophen, but you can also have problems with other NSAIDs, so like Motrin, ibuprofen. Whereas Tylenol causes liver damage, those are going to cause kidney damage. So if you hear Motrin overdose, just think of all the things that can result from kidney renal failure. Okay, moving on to abuse. So abuse and neglect, based on some 2012 data, there were about 3.4 million referrals, which was about 6 million kids, because each referral might be for a household that has more than one kid. Anyway, 3.4 million referrals to Child Protective Services in 2012. Of those 6 million kids, only 678,000, or I don't know which way you want to look at it. not a very big percentage, but still a lot of kids that were the victims of abuse and neglect. And of that, about almost 1,600 died from the abuse or neglect. So there's a lot of different types of child abuse. You can have physical abuse, neglect, which is not necessarily active abuse, but not providing the care or, basic needs of the child. Sexual abuse, and then Munchausen syndrome by proxy, which I don't go over the last two in this. Well, I don't really go over the last three. But some things to think about with Munchausen: if you have a kid who's having symptoms, but they seem to only have symptoms when parents are around, questions like that, that's where you think that's, if you don't know what that is or don't remember off the top of your head. Munchausen syndrome itself is where it's the syndrome, it's like a mental illness where you want to be sick, you want the attention of caregivers, so you do things to make yourself sick. And then Munchausen syndrome by proxy is usually a parent making a child sick, again, to get the attention of healthcare workers. So it's the kids that come in with, some kind of symptoms, some kind of problems, but it's things that the parents are doing to them that's causing those problems. Okay, so abuse and neglect, some risk factors. So usually for the kid, a risk factor for kids being the victims of abuse, the younger they are, the higher at risk they are. So especially less than 3, thinking of all those crying babies that stress out parents and the things that they can do to younger kids who can't help themselves. Kids with learning or developmental disabilities, anything that adds to that stress. History of unexplained or repeated injuries. If they have prolonged crying or colic, so those colicky babies that are crying all the time, again, stress out parents wanting to make them stop crying. And then something, if you see multiple absences from school, can kind of be a red flag that there might be something going on. Parents' risk factors or things that might make them more likely to be abusers is if it was an unwanted pregnancy, environmental stressors, if they are an adolescent parent or a single parent, just not having the help they need, think about anything that increases stress in their lives. And then some people mix that with poor coping mechanisms is a recipe for risk factors for abuse. Inappropriate delay in obtaining help for their kid if they don't get the help that, don't recognize their kid needs help or get it when they need to. If they have a personal history of domestic violence, so either they have a history of violence against them perpetrating the violence or domestic violence against them, that can make them more likely to become abusers, unfortunately. History of substance abuse, unwillingness to provide information. So they're, they're like, I don't know what happened, or showing a disinterest in the child. And unfortunately, this is kind of a, I don't know what my brain is fried from the last 6 weeks and I can't think of it, but, we have a saying that it's always mom's boyfriend, unfortunately, but like some other person who is entrusted with the care of the child who's not actually the parent of the child, who may or may not perpetrate abuse. Clinical presentation. So the biggest one we see in the ICU, and this is probably not the biggest one in general, but for what we see in the ICU that comes to us is going to be traumatic brain injury. So something like shaken baby syndrome, or other things, that cause traumatic brain injury. But you can also see abdominal trauma, chest trauma, burns, asphyxiation, suffocation, or near drowning. So some characteristics. So you're going to look at the general appearance. If you see multiple injuries in various stages of healing, that means there could be chronic abuse that's going on. They do, hit them or something 1 week and that starts to heal, and then they come in with another injury or broken bone. Multiplanar injuries from multiple sources, obvious pattern to the injuries, assaultive location. So where, kids shouldn't normally be getting bruised. I mean, I can show, Jax has little bruises all over his shins, but he doesn't have them over his kidneys. So things like that. Burns, fractures, bruising, just looking for patterns. Differential diagnosis. So you want to make sure, obviously, if you see things that trigger abuse in your head, you want to make sure you're ruling out other causes. So was there an accidental trauma? If they're a baby, was there some trauma during birth? Do they have any coagulopathies? These are the kids with some kind of hemophilia or ITP or something like that that's causing a lot of bruising. osteogenesis imperfecta, where their bones are so fragile they break for almost no reason. Glutaric aciduria type 1 is a genetic disorder, and infantile rickets. All of those can cause either increased bruising, more likely to have broken bones. So what are some keys to diagnosing non-accidental trauma? So again, a physical exam that's not consistent with the history. So you're seeing one thing, they're telling you something else. Multiple injuries in various stages of healing, or any unexplained injuries, shock, cardiac arrest. Or they're like, I just found him not breathing, I don't know why. It's not always abuse, but those are going to trigger you to look for it. So shaken baby, this is an intentional traumatic brain injury, non-accidental trauma brain injury. It's the leading cause of death from non-accidental traumas, because obviously it's causing the most damage in not a good area. So it's the most common ICU presentation we see of non-accidental traumas. A lot of the other ones don't require ICU care. And this comes from physical abuse, and it's the leading cause of traumatic brain injury in infants. So you have with this intracranial trauma, so think of how hard they would have to be shaking the baby. It could be with or without other fractures, depends, what else they were doing at the time. You're usually going to see subdural hematomas. You can see cerebral edema, subarachnoid hemorrhages, retinal hemorrhages, again, rib fractures, depending on where they were holding the baby, fractures of the long bones, and then a history of previous abuse, because usually it's not the first time and it's not the only time. Skeletal traumas. So this is, broken bones. You want to look, if you're thinking abuse, for multiple fractures, again, in multiple stages of healing. Infants, if they have rib fractures, again, we talked about this in pulmonary, but the ribs are pretty hard to break in an infant. So if you see rib fractures, that's kind of a red flag. Fractures of the mid to distal third, so the furthest third of the clavicle or scapula, that's not a normal place for a break to occur. And then skull fractures with no history or witness trauma. So a sketchy history, I didn't see it, don't know what happened, or the story doesn't match. So, because I think a lot of times these people are, they probably know that they can't come up with a good enough story. And so they're like, oh, I was in the other room. And of course, kids can get hurt when you're in the other room, but that's a common theme of the history that you get with a non-accidental trauma. Abdominal trauma. So this only makes up for 2 to 5% of abuse cases, but it results in 40 to 60%. Well, what I said it the wrong way. 40 to 60% of the abdominal trauma cases result in death. So it's a low incidence, but a high mortality area. So usually with this, you're going to see damage to multiple organs, their liver, the kidneys, their intestines, pancreas, and they're going to come in with fever, sepsis, hypotension, hypovolemic shock. So think, kids kicked in the stomach or whatever. They need rapid assessment and resuscitation. How do you see if it's accidental or non-accidental? Well, again, you're going to look at the history. Is it consistent with the injury? Usually accidental is just one organ. You see them liver lack, kind of one and done hit that either hits their spleen, their liver, their kidney. With non-accidental, you're more likely to see multiple organs affected, though you can obviously see that with accidental as well. And then both of them with or without bruising. Moving on to burns. And this is all I talk about burns. You can talk about burns for a long time with, just in general burn management, whether or not it's related to abuse. So you might want to do a little bit of study on your own of burn management. But the biggest thing with that is like lots of fluid resuscitation. They have lots of fluid loss. But in regards to abuse, it makes up for 6 to 20% of pediatric abuse cases. And it just, depends whether or not they need ICU admission. They may not, but you can see immersion burns. So this is where, they make a very hot bath or something, and put the kid in it, or put the kid in the bath and crank the heat up on it. Usually you'll see a line of demarcation. So usually you think if a kid goes up to hot water and puts their hand on it, they're going to splash around and be like, ouch. But if it's a adult putting them in the water, you're going to see a line of where that burn ends. Or especially the glove demarcation is where they dip their hand in. You see like a nice line around. We've had some before of like, I don't know, I can't remember if this one ended up being determined to be accidental or non-accidental, but where very hot milk fresh out of the microwave was spilled all over an infant, and he had very bad burns all over his face and neck. And I can't remember, I don't know if Melissa or someone remembers if that was accidental or not, but anyway, but usually if a kid is splashing hot water either from the stove or something, or, spilling hot liquid on themselves, there's going to be splash marks. That's all that I mean by that. Uniform contact burns, think cigarette burns, bilateral burns. The incidence of burns in general seems to be declining, but highest risk are the lower in age they are, the more at risk they are. And most common is scald burns, and that would be from like hot water. Okay. Melissa doesn't remember. Okay, never mind. Hyperthermia and hypothermia. So hyperthermia, this is a body temperature above 37.5. You have some kind of failure of your body's thermoregulation. So usually, it can be from fever, but we're going to start kind of talking about heat stroke, heat exhaustion. So think environmental heat is high, causing an increase of body temperature. Sorry, that tickled. So it can range from anywhere from minor to life-threatening effects. It depends how high the body temperature goes and how long. So again, due to either excessive environmental heat, you're out in the very hot sun for a long time, or a baby left in a car, and or combined with your body's inability to dissipate excessive heat. So younger babies especially don't have as good of ability to dissipate heat. So the younger kids are at higher risk because they have a higher metabolic rate. They're producing more heat inside their body to start with. They also have a smaller blood volume, which is how your body can help dissipate heat. They don't sweat as much, especially little babies, and they tend not to rehydrate. So depending, I think infants can't physically go pick up their bottle themselves. And then toddlers, they may be out playing in the hot sun and not think about rehydrating themselves. Heat exhaustion. So this is an elevated temp, but still less than 40 degrees. So they're still going to be awake and alert. You can see fainting though with this. They're going to have that mild to moderate dehydration level. They're going to be tachycardic, but have a normal blood pressure. They're still going to be sweating, but have some maybe nausea, vomiting, headache, fatigue. Heat stroke is the next level. So characteristics of this, it can be exertional or non-exertional. It could be they're out, actively involved in some sport in the hot sun. It can be non-exertional, again, from a baby being left in a hot car. This is where their temperature is above 40. Some of the literature says 40.5, but just think above 40 degrees. They're going to have an altered mental status. They're going to have moderate to severe dehydration. They are going to be tachycardic and hypotensive. At this point, their sweating has depleted itself, so their skin is typically going to be very dry. You could see vomiting. And then the longer they are, the longer this excessive heat goes on, they're going to go into DIC, rhabdomyolysis, and organ failure. So how do you assess this? Core temp, obviously it's too hot, so their temperature is going to tell you. Their blood glucose, usually they're going to be hypoglycemic because they've been burning through all their glucose. You're going to look for all their labs, DIC, electrolytes. The big ones that you'll see elevated are usually sodium and potassium. The sodium's high because they're dehydrated, potassium because of that cell damage and death. Assess for rhabdo, assess for organ damage. And then interventions, help me please. So remove them from the heat source, cool them as soon as you can. IV resuscitation just with room temperature fluids, because room temperature is going to be much less than their body temperature. Get a CVP if you can to assess their fluid needs, because again, at this point, they're probably going to be severely dehydrated. Vasopressors if needed, benzos for seizure activity. You want to prevent shivering. So as you're cooling them down, you do not want them to shiver. That's going to increase their metabolic demands. and make it worse. So prevent shivering. So you might need to give benzos in order to prevent that, but no acetaminophen or ibuprofen. First of all, because we're talking about heat stroke, not a fever. So we're not giving antipyretics to treat a fever. That's not the reason their temperature's elevated, but also because, again, if they are at this point, they're having organ damage, they probably are having some liver and kidney damage, and acetaminophen, ibuprofen, or liver and kidney, that's just going to make that worse. Hypothermia. So this is a core temperature less than 35. Kids are at higher risk because they have a larger body surface area. They're getting rid of too much heat, or, that heat can come off them too much. They have less subcutaneous fat to insulate them, and younger infants cannot shiver, so they cannot increase their own heat through shivering. So mild level, they're going to have some shivering. They're going to have vasoconstriction as their body tries to compensate, but as it gets to moderate hypothermia, the shivering is going to start to stop. They're going to start to have slurred speech, become clumsy, confused, variable vital signs, and EKG shows slowing of their impulses. So everything's slowing down. So prolonged PR, widened QRS, prolonged QT interval. Severe hypothermia, they're going to start to be very bradycardic, hypotensive. They can be in a stupor, becoming unresponsive. And then as it gets worse, you're going to progress to VFib, PEA, asystole. Hypothermia assessment. So again, temperature, you want to see what their temperature is. You're going to start to rewarm them, passive, get them out of whatever cold environment they're in. And then active external from like bear huggers or things like that, active internal, warm IV fluids. And then use caution with external heat if they're very hypothermic. So if they're severely hypothermic and you add heat, it's going to cause vasodilation, and it's not going to get, their blood's not going to go where it needs to go. So you want to use caution with external heat on them. And then resuscitation, if it's bad enough and they're in a non-perfusing rhythm, you may need to resuscitate them. Okay, submersion injuries. So this is drowning. Used to be called near drowning, but they're getting away from that term apparently. So now we just call it drowning, and it's either fatal or not fatal. So what are some risk factors for this? So either they're overestimating their swimming abilities, teenagers who, are a little too risk-taking behavior. I was in college and had a couple of, I didn't know them, but a couple of the kids at my college drowned because they went surfing in a hurricane, which is just all kinds of stupid, but anyway, so risk-taking behavior, lack of supervision, kids that, toddlers wander out and fall in the pool, epilepsy or underlying cardiac dysrhythmias, because those, even if they're swimming, if they're in the water and those things happen, they lose consciousness and can then drown from that. And then hypothermia is a risk factor. So we know that kids who drown in cold water and are hypothermic, when they come in, do better, because they don't get as much brain damage. But if they're hypothermic when they go into the water, so they're already in a cold environment, they fall into cold water, they're going to have muscle incoordination and weakness because of the hypothermia, which is going to increase their risk for drowning. So this can happen domestically, inside the house, tub, toilet, artificial, so think pools, natural freshwater, lakes, and then salt water is the least likely. The categories, again, it can be fatal or non-fatal. They're not calling it near drowning as much. Saltwater versus freshwater. And then usually we want to categorize it as cold versus warm. And the cutoff for this is 20 degrees Celsius, which is, to me, too cold to be warm. But I don't want my pool to be that cold. But as far as the cutoff for whether it's cold water drowning or warm water drowning, that's the cutoff. So what happens? So liquids aspirated into the airway. At first, you're going to get a coughing reflex and a laryngospasm. So your body's going to kind of react by spasming a laryngospasm to try to cut off and keep that water from going in, but that's going to make it so you can't breathe. So you're going to have hypoxia, hypercarbia, acidosis. As your oxygen levels decrease, that laryngospasm releases because your lungs are like, I need air, but if they're still in the water, that liquid's going to be aspirated. And then they're going to have a loss of consciousness. Their brain's not getting enough oxygen. So inside the lungs, you're going to have intrapulmonary shunting of blood through areas that are poorly ventilated. So your blood, it's a it's a type of VQ mismatch, but your blood's pumping through areas that aren't getting air because either they're filled with water or they've, the alveoli has been damaged. And the water and stuff causes bronchospasms, causes damage to the alveoli, and can decrease your surfactant or wash it out, kind of. For your heart, it's going to cause the hypoxia and acidosis can lead to dysrhythmia. So you may see initially tachycardia followed by bradycardia and PEA and then asystole. You can get peripheral vasoconstriction. If they fall into cold water, they're going to clamp. All their, vasoconstriction is going to happen peripherally to shoot their blood to the core because of the cold water. Because of that increase of volume internally, you can intermittently, their body might think, oh, I have too much blood volume, and increase or decrease the production of ADH, which causes them to dump fluid, which is kind of going to make your body thinks one thing's happening and it's not, can make them diurese when they need that fluid inside. So what you're going to see, usually hypothermia, whether or not it's cold or warm water, you're typically going to see hypothermia because even if you think of normal pool water, it's still usually, except in the middle of August in Texas, it's usually still cooler than your body temperature itself. So you're going to see hypothermia to some degree, a decreased cardiac output. You're going to see CNS ischemia. So they've had some kind of cerebral hypoxic injury that's going to cause ischemia, can cause increased ICP that might not develop for 2 to 3 days after submersion. Persistent hypoxemia, acidosis, and then your electrolyte imbalances. And those are the most common: hypoglycemia, hyperkalemia, and hypophosphatemia. So you're going to put an NG tube in to reduce any risk of aspiration. Intubation, they might need more PEEP, especially if they've had damage to their alveoli and lost their surfactant, they might need that PEEP to help open up those alveoli back up. Plus the pulmonary edema that's likely happening, PEEP is going to help with that. They probably need fluid resuscitation, correct acidosis, correct electrolyte imbalances, give them inotropes, bronchodilators to help with any bronchospasms. So complications that come from this, obviously they're probably going to go into some kind of ARDS. Again, you're going to see bronchospasms. You're going to have cardiac problems, coagulopathy, all of these things. All right, that's all the review. And again, go over post-transplant stuff at your leisure. But hopefully we can get through these practice questions. We'll see if this works. And I did include some of these that I didn't necessarily review the material for, but just to kind of give me a chance to go over that concept. So if you see a question we didn't go over, sorry, I did it on purpose. All right, go ahead and read this while I get the poll loaded up. Sorry, can't find where I'm going. There it goes. Okay, so a child's admitted with a tricyclic antidepressant overdose. The most worrisome arrhythmias seen with TCA overdose are. Oh, I should have made a note for myself. I forgot to tell you what this is. So we'll see if you know. If not, I will tell you in a second. Only 3 of you have answered or even started. Ooh, 5 now. Ooh, 6. Let's see. In the meantime, I'll show you Belle. She got spayed a week ago, so she's in her cone of shame. Let's say hi, Belle. She's still a good little guard dog, even in her cone of shame. Okay, I'm going to go ahead and start closing it, even though there's still about half of you that didn't get a chance to participate, but hopefully you will with the next one. So the answer is ventricular. A lot of you chose blocks, which I think is actually what I chose, not having studied this and doing the practice questions. I thought blocks was a good guess, and it is a good guess, but it's not right. It's ventricular arrhythmia. So with serious tricyclic antidepressant intoxication, cardiac rhythm disturbances are common and often lead to ventricular arrhythmia. So again, sorry I didn't go over it. This was my opportunity to tell you that. But a lot of times you'll see it's tricyclic antidepressants usually have anticholinergic effects. So you're going to see some of that stuff similar to Benadryl, and then in addition, ventricular dysrhythmias. Okay. Try this one. Okay. While caring for a patient after a kidney transplant, the nurse notes an abrupt decrease in urinary output. No kinks are noted in the indwelling catheter system. What's the most appropriate initial intervention? So initial is the important thing. So administer Lasix, irrigate the urinary catheter with sterile saline, promptly replace the urinary catheter, or administer 20 per kilo bolus. Okay, give you a few more seconds to start if you haven't already. All right. So it's kind of across the board, but the correct answer is B. So irrigate the urinary catheter. So especially after kidney transplant, you can still see clots and things for a while that might clog it up, and keeping the bladder decompressed is very important. So the first thing you're going to want to make sure is that urinary catheter is draining properly. So there's not any outward kinks, but there might be a clot or something inside that's blocking it. So usually irrigate with saline. You might, it didn't have the choice, but you could do a bladder scan to see if the bladder was filling up with urine. Because usually after kidney transplant, they have quite a bit of urine output for a while. So, all right. Okay, a 12-year-old is admitted after an accidental shooting to the femur and pelvis. Significant blood loss has occurred. Following adequate fluid resuscitation, perfusion remains poor. Oxygen requirements and work of breathing are increasing. Vital signs for a 12-year-old are heart rate of 136, respiratory rate of 24, and a temperature of 101.5 or 38.6. The nurse should suspect uncompensated hypovolemic shock, multiple pelvic fractures, long bone fracture, or acute systemic inflammatory response syndrome, SIRS. I hope some of you are in your car or something, and that's why you're not doing it. So there's still only about half of you that are answering. Again, I can't see the answers. You can guess whatever you want. I'm not going to be able to tell who said what. Belle wants down, so say bye, Belle. Oh, it's okay. All right. Start to close this out. I'll give you a few seconds to finish if you've not put in your answer yet. Okay. Answer is SIRS. So again, SIRS is in response to any kind of illness, injury, infection. This one is an injury. It's characterized by abnormal temperature and one other thing. So we've got abnormal temperature and tachycardia. A little bit, 24 is a little bit tachypneic too for a 12-year-old. So all of that qualifies for SIRS. Let me share. Unfortunately, a lot of you were guessing uncompensated hypovolemic shock, which is not a bad guess. We know that significant blood loss has occurred, and we are still, tachycardic. The key here then is the temperature. That should point you to SIRS. Okay. Okay, a newborn with hypothermia and hypoglycemia has an absolute neutrophil count and an immature / total neutrophil ratio of 0.3. Based on the findings, the nurse prepares 2. So this is one of those questions that I've seen before where it's like a measurement that we're not used to. So you kind of, in this case, have to think through, like, if that ratio is that, what does it mean, kind of thing. And also, I think this is one that I got wrong. But anyway, would you administer antibiotics, repeat a CBC in 4 hours, obtain a blood culture, or administer IV fluids? All right. I'm going to start to close it out. We got about 15 seconds to finish up thinking about your answer. And so it's kind of split. And I think, to be honest, I picked what most of you picked. Most of you picked blood culture. I think I picked that too. They're saying antibiotics. So again, this is one of those where they wrote the question, and I don't know how much I can argue with them. That ratio, all of you were on the right track. It means infection. The immature to total neutrophil count, the ratio, it should be lower than that. It's, kind of also, it means there's too many immature neutrophils, which means an infection is going on. But as far as blood culture versus antibiotics, obviously, I think you should get a blood culture first, but I guess they're going back to the principle that if this is sepsis, antibiotics are a priority. I think culture should be first, but they didn't really tell us we couldn't. I don't know. I have an issue with this answer, but I'm just showing it to you so you get kind of what they say is their reasoning behind it. But antibiotics are, quick administration of antibiotics is important for sepsis. So I guess that's where they're coming from. But don't feel bad if you missed it. I did too. Okay, factors that impair the release. This is kind of a throwback. We didn't talk about this today. It obviously is a big factor in shock and sepsis, but we talked about it way back in pulmonary. That oxyhemoglobin dissociation curve. So factors that impair the release of oxygen to the tissues by negatively affecting the oxyhemoglobin dissociation include, this is preventing release of oxygen to the tissues. Hyperthermia, metabolic acidosis, respiratory acidosis, or hypothermia. So, get a few more seconds. Okay, I'm going to start to close it out, so you have about 10, 15 seconds to finish your answers. And so in this one, if you don't remember exactly what that curve is, it's helpful to at least, hopefully, go back and study it, but at least try to group the two sections together, of which I'll show you the results. There was a group that impaired the attachment of oxygen to hemoglobin and made it easier to release from hemoglobin, and one that impaired the release of oxygen from hemoglobin. So if you at least remember what the two groups are, then maybe you could have figured, maybe that helped you figure this out. So in one group was hyperthermia and acidosis, wherever it comes from, metabolic or respiratory. So that kind of puts all three of those in one category. So hypothermia is the odd one out. So in this case, it was hypothermia. It results in a shift to the left. Not that you have to remember if it's left or right. Just remember which group makes oxygen bind to hemoglobin and which group makes it release or not bind to hemoglobin. So too much hypothermia results in oxygen that binds too tightly to hemoglobin, which makes it difficult for then that oxygen to release when it gets to the cells. It doesn't want to release and go into the cells. So, that was a review from way, way back, over a month ago now. Okay. A patient is admitted after ingesting kerosene. A chest x-ray 2 hours later indicates aspiration and a whiteout. What intervention should the nurse anticipate? High-flow nasal cannula, parenteral nutrition, and antihypertensives. Mechanical ventilation, fluid, and vasopressors. BiPAP, NPO, and sedation. Or supplemental oxygen, good nutrition, and an H2 blocker. I don't know if you can see the tiny puppy behind me. She likes to get up on the top of the couch. She thinks she's big stuff. She's 3 pounds. All right. We'll go ahead and start to close it out. So you have 15 seconds to finish your answer. Ooh, we're pretty split between the aggressive people and the not aggressive people. Let's see which ones are right. So, 2, 1. Half of you chose B and half C. The answer is B. So C, that's could be a first step BiPAP, with a whiteout and aspiration of kerosene, which is a hydrocarbon, that's going to cause that chemical pneumonitis. So they probably do need some kind of ventilation. BiPAP might be a good choice, except a whiteout is really bad after just 2 hours. So they're going to need more aggressive intervention than that. So if it had just been, somewhat of a patchy x-ray, BiPAP might have been a good start. But a whiteout after 2 hours is not good. It can cause severe respiratory failure, chemical pneumonitis, ARDS very quickly. So you're going to want to go ahead and intubate them, give them fluids. They're probably going to go into a shocky, just anticipate them going into a sort of shock. So, okay, here's the next one. Okay, a 10-year-old admitted following an open reduction of a radial fracture develops fever, tachycardia, and tachypnea. Priority interventions include which of the following? Is it pain medicine, saline bolus, 20 per kilo bolus, and a CT scan of the chest? Is it antibiotic administration, O2 at 2 liters, and pain medicine? Is it antibiotics, 20 per kilo of saline, and antipyretics? Or is it antipyretics, 1,000 mLs of saline, and a CT of the chest? Give you a few seconds. Gonna start to close it out. 15 seconds. Okay. So this one, looks like none of you chose it. I think I got this one wrong too. So with fractures, one of the first things you might think of, especially with tachypnea, tachycardia, is I'm guessing some of you were thinking of a pulmonary embolus, like a fat embolus. With that, the test of choice is not a CT scan, it's a VQ scan. But what they're getting at here is a possible infection. So an open reduction means that some kind of surgery has been done. So if they're being admitted after an open reduction, a surgical repair of an open fracture, and they have fever, tachycardia, then it's probably, they're getting at the fact that it's an infection. So antibiotic administration, which some of you chose B, which included that. And that's a good one to choose too, because oxygen delivery, if they are starting to have an infection, pain medicine. But if they are getting an infection it's starting to cause a systemic response, because this is fever and tachycardia. It's not just pain and redness at the site. It's starting to become systemic, which means they probably can go into a shocky picture. So they're going to need antibiotics. That's where the fluid bolus comes in. That it's starting to have that systemic inflammatory response, that SIRS response, and then antipyretics for the thing. So that one was kind of tricky, I thought, which is why I included it. Okay, 2-day-old infant dies shortly after admission to the unit. The parents chose to wait outside the unit during resuscitation efforts. The nurse should first. I don't know why this was in the multi-system section of questions I did, but I thought it was a good review of way on back to the first to synergy, because that is a big part of the test, 20% of the test. One of the biggest sections is synergy, which to me, this is a bit of a synergy question. So do you take the infant to the parents? Refer the parent. What would you do first? Refer the parents to a genetic counselor, clean the infant in the room, or prepare a memory box for the parents. A few more seconds. Canvas. Oh. Usually it gets 15 seconds, but you all must have, the ones who started had already answered. So here, the ones who answered all got it right. You're going to clean the infant in the room. So it may help, especially if they didn't want to be there during the resuscitation. We want to try to decrease their emotional impact as much as possible. So cleaning the infant up, cleaning the room up, getting any blood or betadine off of them will help decrease the emotional impact. Okay, a teenager is admitted after ingesting 25 unknown pills. So this is where you're going to have to use those toxidromes to figure out what it is. So assessment reveals drowsiness. The patient states monkeys are flying around the room. They have a heart rate of 136, a blood pressure of 78/30. SATs are 100% on room air. They have not voided, and when awake, they complain of dry mouth and blurry vision. Their pupils are 8, equal, round, and minimally reactive to light. Which medicine do you suspect? Sorry about that. Okay, so I'm going to start to close. You got 15 seconds to finish your answer. So some of the keys here are the hasn't voided, dry mouth, blurry vision, dilated pupils, and hallucinations. So the answer is going to be Benadryl. So diphenhydramine, it's a potent anticholinergic. So there's a common symptom with anticholinergic or cholinergic anticholinergic effects. It's can't see, blurry vision, dilated pupils, can't pee, can't poop, can't spit, which, you can say it a different way and substitute poop with something that rhymes with spit, but I'll let you say that to yourself. But most of you got that right. Good job. Next. 5 months after receiving a kidney transplant, a patient is readmitted with unexplained fevers, fatigue, malaise, and night sweats. The nurse should suspect the complications are by which of the following illnesses? Cytomegalovirus, varicella zoster, Epstein-Barr virus, or herpes simplex. And I realized we didn't go over kidney transplant today, so I kind of don't feel bad if you don't know this. I didn't know it off the top of my head, but I put this in to give me a chance to go over it at least a little bit. Okay, I'm going to start to close it out. Oh, again, close it right away. Of the 4 of you that answered, you were all across the board. So, yeah, again, I know I didn't cover this today, so I'm covering it now. This is that PTLD that I kind of briefly referred to, but post-transplant lymphoproliferative disease. It's a serious complication from patients taking immunosuppressant medications. Usually occurs in the first 2 years after transplant, and the most common cause of it is Epstein-Barr virus. That's 80 to 90% of the cases. So if you didn't know that, don't feel bad, but EBV with a post-kidney transplant is bad, causes PTLD. Okay. Just a few more. 4 more. Okay, a child is admitted to the unit with a urticarial rash, lower lip swelling, and wheezing. Which medication does the nurse anticipate the provider ordering? Epinephrine, diphenhydramine, albuterol, or Decadron? I'm going to start to close it out. So you got about 15 seconds. And looks like you all got it right. It's epi. Of course, for an allergic reaction, we can give Benadryl, we can give dexamethasone. For wheezing, you can give albuterol, but all of that, the rash with the swelling, wheezing is involving, so we have skin and respiratory involvement. That's the definition of anaphylaxis. So, or that's, how you diagnose it. So epi, IM epi is a first line treatment. It's a short half-life, so you're probably going to be giving the other things, but that's the first one you're going to give. Oh, sure. All of you got it right. Yay. Okay. This is another one I know I briefly mentioned something. This is one where if you know a little bit of something about Motrin, you can maybe figure this out. Because I found that's kind of what you see on this test. Things that you didn't quite study, but you kind of know things that help you find the answer. So a patient is admitted with an ibuprofen overdose. What EKG finding would indicate a toxic drug level? A rhythm strip showing A, peaked T waves, B, a prolonged QT interval, C, a widened QRS complex, or D, an ST segment elevation. Okay, we'll start to close it. And a little bit all over. Only one of you picked the right one. And I think I got this wrong when I was going through the practice questions. I was just thinking, well, Motrin must cause an arrhythmia I don't know about, so I just picked one. But this was a little bit deeper thinking than that. So Motrin itself doesn't cause arrhythmias, but Motrin overdose can cause renal failure because it's processed in the kidneys. It causes renal failure. If think NSAIDs cause renal failure, whereas Tylenol causes liver failure. So that renal failure is going to cause hyperkalemia, and that's going to cause the peak T wave. So it's kind of a multi-step thing to think through on that one. So if you were like me and thought that it just was getting at some arrhythmia that Motrin itself causes, that's, I think I picked B, like a few of you did. But it was going through that thought process. Okay. Mechanically ventilated child recovering from septic shock has the following blood gas results: 7.52, CO2 of 45, O2 of 95, and a bicarb of 32. What intervention is most likely contributing to these results? Which one is causing this blood gas? Is it hypoventilation, spironolactone, Lasix, or hyperventilation? So you first have to look at that blood gas, think, is it metabolic or respiratory? Is it acidosis or alkalosis? And then pick the one of these that causes that thing. I'm going to start to close it out now. Got about 15 seconds to think about your answer. And okay, kind of across the board. So this is alkalosis because your pH is above 7.45. It's metabolic alkalosis because your CO2 is it's on the high end of normal, but a high CO2 is going to cause acidosis. So that's not what's causing the problem. If alkalosis is the problem, it's not your CO2. The CO2 is not the reason for that. So the hypo and hyperventilation are out of the running. So your bicarb is high, which means it's a metabolic alkalosis. So with this, if you're not super familiar with the kinds of diuretics, you might not know which one to choose, but specifically loop and thiazide diuretics like Lasix cause renal hydrogen loss. They also cause potassium loss. Think like alkalosis, K is low. Alkalosis, your K is low. So Lasix is causing low K. It also causes alkalosis. So metabolic alkalosis from diuretics, specifically the Lasix. Last one. Okay. When treating a patient with hypovolemic shock due to prolonged vomiting, the first action by the nurse should be A, increase the maintenance IV fluid rate, B, prepare equipment for intubation, C, prepare the patient for central venous line placement, or D, administer oxygen. What's the first thing you would do? The first. I thought this one was a little tricky because I didn't like any of the answers. It's like, where's the fluid bolus? Okay. I'm going to close this out. Kind of across the board, I think I picked the wrong one on this, but they're wanting oxygen. So this patient's in shock. We probably should be giving them a fluid bolus. Increasing their rate is not going to do much in the short term. But the first thing to do for a patient with shock, they're having, a characteristic of shock is poor perfusion for some reason. So administering oxygen is going to help optimize at least the oxygenation of the blood that is perfusing. So again, I thought that was tricky. I didn't super like that question, but anyway, stop sharing. Okay. Thank you guys for joining me today. I was going to just, hold on. Where's my thing? At the end here, let you know a couple of things. So I think I mentioned in one of the first sessions that I was going to retake this test as my renewal this year. And I took it this morning. And I was just going to share, if you all have time, a little bit about how it went. They make you sign a bunch of stuff that says you're not going to share the contents of the test itself. And I don't want to get my CCRN taken away, so I'm not going to share too much about it. But I will just say, it was, I think, I said, I think last time, or when I took it 10 years ago, it was like an H&R Block. This one, it was actually called a PSI testing center. It was inside a big office building. But when you went inside, the name of the office was PSI Testing Center. One of the interesting rules that I didn't see before I got there, and I'm glad I dressed appropriately, was you can't wear a hoodie. Don't wear a hoodie, or especially if it's a shirt that is not like a separate hoodie. Don't wear anything with a hood. They're going to take your picture like that to make sure it's you. Take 2 forms of ID, so your driver's license and something else that has your signature on it. So a credit card's fine, but I didn't sign mine in the car. And you will get a whole printout of a breakdown of your score. You can kind of see it breaks down all the different sections: so cardiovascular, respiratory, endocrine, neurological, multisystem, and it tells you the max score for each section and how many you got right. So the number of questions for each section and the number you got right. So it was 150 questions. Only 125 are scored, like I've said before. And so it'll tell you how many you got right out of 125. The cut score, this is consistent with what the website says. So the AACN website tells you that the cut score, the minimum you have to get right is 82 questions out of 125, which is pretty, I think, generous. I mean, it's like 65%. So that's the minimum you have to get right in order to pass the test. And then it kind of tells you how you did in each category. So I did pretty good. My worst ones were actually multisystem and professional caring and ethical practice, because I guess that's not my strong suit. But one of the, again, I think one of my big takeaways is this test covers a lot of stuff, and it's really hard to cover everything. So when you're going through, really focus, especially with stuff like in multisystem with overdoses, there's a bunch of different meds and classes of meds they could ask about. And I saw some things I wasn't necessarily expecting to see. But I mean, that was a couple questions out of all of them in the test. There was, anyway, of the ones that I was like, I didn't even look at this. I didn't remember studying this at all. But that's a couple questions out of the 125 you have to get right. So, I mean, the biggest sections are going to be synergy. That's 25 questions that are scored. So make sure you go over that section really good. Go over cardiovascular or pulmonary. Those are 2 big sections that make up 18 and 22 questions respectively. So make sure you're really focusing a lot of time on those areas that do get a lot. Go over some of those meds that we didn't necessarily go over a lot. And like digoxin, the different cardiac meds, especially if you're not as familiar with those, and things like that. But if you guys need anything or have any more questions as you're preparing for the test, let me know. I did want to ask, or I'm going to do one more poll question if it'll let me. I would like to know when or if y'all are planning to take this test. Hopefully, if you've spent 12 hours with me, you are planning on taking it. So I just had a quick poll to ask you if you've signed up for it and when you're planning on taking it. I would appreciate any feedback. I mean, this is the first time I have done this full review course like that. The past 2 years, I've only done that very first session that we did. Actually, just the first part of that session that told about the test and what to do to prepare for it. This is the first time I've gone through and done a full content review. So I would really appreciate the feedback you guys have. I do plan on doing it again. Well, whether or not I do it again next year probably depends a lot on how many people actually take the test from the people who took the class, to see, if it was worth the time and money they're paying all of us in education hours, whether or not that actually converts to people taking and passing the test. So if you do take the test after this, please shoot me an email and let me know. There's not really a way otherwise for me to know that you took it. So please let me know if you do take it. And yeah, if you have any questions going on, any feedback at all for this course, and suggestions of how it could be done better next year, if we're able to do it next year, would be appreciated. So, but in general, where did my polling go? There it is. Looks like I'll show you guys these in case you want. So one of you says you have applied to take it, so that's good. Others not yet. Now that you've finished this course, if you're in the PICU, you can ask Kendall or Kelsey for one of the vouchers. I would already have that paper application filled out and ready to show them that you are ready to apply. And I mean, if you're planning on taking it, most of you who are answered, want to take it in the next month before the end of the year. Obviously, I think probably sooner, so that this stuff is fresh in your mind, is better. Especially before we get into the busy winter season / holidays, just personal busyness. But yeah, go ahead and apply. And to me, the biggest thing that helps is putting that application in. It puts an end date, a due date on when you have to take the test, and then you have to schedule it. And that kind of forces you to study too. So that's one thing I would recommend for that. But anyway, thank you guys so much for joining me for all these sessions. I really appreciate again, any feedback you guys can give, and I really hope this was helpful for you. Please let me know how it can be more helpful even for, future sessions. So thank you guys a lot. I hope you have a good rest of your week. And yeah, let me know when you take it and when you pass it. Thanks, guys. Lauren says, I'm registered to take it on the 20th. Depending on the location you pick, times and days are hard to come by. Yeah, especially when I went today, you can tell they have a lot of their, you go into this room. If you've taken the NCLEX and stuff, you're probably familiar with the setup of these rooms, but it's this room with a bunch of little cubicles, and they have half of them at least blocked off because of COVID, social distancing stuff. So I'm sure there's a lot fewer times available. So yeah, make sure you're going ahead. And I, they said you only had 90 days from when you registered to take it. And I don't know if it's any different for renewal. When I registered, it gave me until mid-February, which was like 23 weeks. So it was way longer than 90 days. So I don't know if that's because of COVID, they've adjusted that or what. So you should have several months to take it. But if your goal is to take it by the end of the year, there's no reason you can't go ahead and apply now. And go ahead and get something scheduled. That way you can go ahead, like Lauren said, pick out a time to do it. If something comes up, you can reschedule it once, but it has to be 3 business days before. So if something comes up that morning, you're kind of SOL. But anyway, any other, if y'all want to catch me and ask me other questions about it, I'm happy to answer them. But anyway, thank you guys so much. And I will talk to you all later. Thanks.